Hello, everyone. As you all know, we are venturing towards our CPD sessions. So here I am today. My name is Foster Joseph, and we are all four physios, which means four gangster, four people trying their best to brush up their knowledge as well and to brush up your knowledge as well. So welcome, we welcome you all. Today our presenter is Amna Jafar. As we discussed last time about rotator cuff injuries, she's just going to add a little bit extension into that topic by discussing it in a more anatomical and more biomechanical angle. So will the topic she's presenting, I think it's called shoulder conundrum, right?
Yes. Shoulder
So
conundrum.
yes, we'll be discussing the conundrum between the shoulders. So let's start, guys.
Thank you so much for having me today. Assalamu alaikum. Sabko.
Walaikum assalam.
Walaikum assalam.
So, without wasting the time, let's start our topic. So, today the topic which I'm going to discuss is about the shoulder conundrum. So, conundrum basically means a puzzle kind of situation, a difficult situation. And I'll be discussing an article that I have taken from Physio First. The author who has written this article, her name is Claire Oakley, and she is basically discussing the complex movements of the shoulder mean that when problems occur, it can be a difficult area to diagnose and treat. So let me just share the picture so you can be more clear with that, yeah. Give me a second, guys. So yeah, here you go. Can you see it on the screen? Just give me a thumbs up.
Yes.
Yeah, okay, thank you. This article discusses the local and global stability systems which affect the shoulder and scapular dyskinesis. It then introduces the concept of diagnosing common shoulder problems through the understanding of movement system impairments. So, wherever I'll be mentioning MSI, it means that I'm talking about movement system impairments. That is very important for the shoulder instability. Yeah. So, basically, what are the learning outcomes? Understand why movement impairments occur. So this is the basic reason, because we have to lead towards a treatment. So as a physiotherapist, we should know what are the movement impairments and how they occur. Then understand local and global stability, which I'll be discussing afterwards. Recognize common movement system impairments, that is known as MSI. Understand how to undertake an MSI based examination. We'll be discussing this shortly and briefly in this CPD module. Then, know how to formulate a treatment plan based on MSI diagnosis. That is very important for us. Okay, so next thing is take home message from this article. So, what will we learn, all of us, inshallah, at the end of this CPD module? That is, don't treat the shoulder in isolation, treat the whole kinetic chain. So, basically, while I was going through this article, it helped me a lot as a physiotherapist, because before, I don't know of for you guys, but I only used to, if I was doing mobilization or massage or giving physiotherapy sessions to my clients, I used to focus on just back or shoulder areas. But going through this article, I got to know that how to be holistically approaching the patient to treat them and give them the best physiotherapy services possible. Look at the movements the patient can't do and ask yourself why. Okay, so this could lead you to formulate a good treatment protocol for your patients. MSI diagnoses are useful for guiding a treatment plan. So, obviously, end result, we want a best treatment plan for our clients and patients. So, I'll be discussing introduction briefly. So, as we all know, that shoulder pain is very common, especially as we get older. It affects roughly 1 in 5 adults. Yeah, and it has been seen the prevalence in females aged between 45 and 64. Are you guys agree with me? Yeah.
Yeah,
Yes.
yeah.
Hmm. So generally, what do you think? Women suffer from shoulder pain or men?
Yes, mostly patients I'm attending is yes. Considering male to female ratio, they are mainly the female population.
Yeah, that's true. And could you tell me the foremost reason? I think for me as a physio, I think because of the menopause. Yeah.
Yes, just because of a lot of hormonal fluctuations
Yeah.
and because of so many other comorbidities like diabetes is a very common factor engaging your
Yeah.
musculoskeletal system.
Mm-hmm.
Again,
Even the
again,
social roles, like social roles,
yeah,
because female are more into household chores, so lots of overhead activities, cleaning, doing all those stuff, this engages the shoulder, overloads their rotator cuff, and they end up coming with
And
their shoulder pains.
yes, agree.
doy,
Yeah,
call it doy, yeah.
yeah.
Okay, so shoulder girdle is a fascinating area to treat. For me, it is, yeah, as a physio. It has amazing mobility, but the range of movement also presents a significant challenge for its stability. When the glenohumeral joint moves, the scapula must also move to allow the repositioning of the glenoid fossa, suggested 1 ratio 2 rule. So, what happens in 1 ratio 2 rule? That the scapula moves around your glenohumeral joint. So, स्कैपुला की मूवमेंट जो है वो किसके अराउंड होगी ग्लीनो ह्यूमरल जॉइंट के सो दैट्स व्हाई देयर इज अ साइंटिस्ट इन मैन ऑथर हैं उन्होंने जो है इसको एक्सप्लेन किया है 1:2 रूल को दैट इज दैट द स्कैपुला मूव्स 1 degree for every 2 degrees of movement by the glenohumeral joint. Let me again share the screen. Share photo. Yeah, okay. So you can see from the figure one, yeah, and obviously when we practically do it, or you can just do yourself right now. Move your shoulders, and you'll feel this 1:2 rule. So for an injured shoulder with inevitable loss of stability, altered movement, and positioning of the shoulder complex happens very quickly. You guys agree with that, yeah? Subtle changes in the accuracy of shoulder movements may cause increased tissue damage and pain. So we come across as a physio with shoulder injuries and stuff like that. We see that people come with tissue damage and pain and decreased range of motion due to adhesive capsulitis, frozen shoulder, tendinitis, tendinopathy. Yeah? Altered recruitment and timing are also seen. This is often referred to a reverse scapulohumeral rhythm and occurs when the large global mobility muscles. So I'm going to mention, we can just memorize the names of the muscles. So the large
It's the
global mobility,
plab
sorry?
muscles,
Yeah, yes, yes,
plab,
yes.
those plab muscles,
Yeah, pectoralis, latissimus dorsi, anterior deltoid, and biceps. Yeah,
biceps. Yeah.
yeah. Okay. There is an imbalance between movement and length of the global stability muscle. So, does anyone remember global stability muscles?
Rotator
Or
cuff.
so basically, let me
No,
just repeat them.
I think
It's
they're lower trapezius. Are we talking about
yeah,
global stability? Your erector
yeah, global
spinae,
stability.
And
Yeah,
your lower trapezius muscle, I guess.
and
and then
latissimus
try.
dorsi.
Okay,
I
global
remember
stability.
in the last
I think
CPD,
latissimus dorsi is the global mover instead of
yeah,
stabilizer.
yeah, global mobility, global mover. Yeah, Foster, you mentioned these muscles in the last CPD. I hope the guys who are watching this CPD
I
would
did, yeah.
be, yeah, will be inshallah answering themselves that they know, because I remember you mentioned triceps, erector spinae muscle,
Yes.
and trapezius. Yeah,
So
Yes,
and
we always
it's
have like local mobilizers, local stabilizers, but then you have global mobilizers. जो बड़े पर्दे पे काम कर रहे होते हैं, like from large angle support होती है, and then global stabilizers. So your
Yeah,
plab muscle is your global mobilizers, and
yeah.
your lower trapezius and your erector spinae, like spinal muscles, are your global stabilizers. But your local mobilizers is your rotator cuff, and your local stabilizer is your serratus anterior.
Yeah, perfect. Thanks. So, global stability muscles, I'll just repeat them again: triceps, erector spinae, and lower trapezius. Yeah. So, the local stability muscles, that is rotator cuff and serratus anterior. Yeah. Two muscles. So, they say that the global stability muscles, that is rotator cuff and serratus anterior, are inhibited, resulting in the humeral head no longer being accurately centered in the glenoid, and the shoulder girdle become compromised. The stability of the trunk and hips are also altered because of the kinetic chains are affected. So that's why we have to approach the joints holistically, not just the shoulder girdle. Obviously, we have to look towards the hip and back. And as we'll move forward with this article, so I'll be asking Foster Joseph to present it practically, the Joe Gibson's techniques. And today, you guys will be learning that, inshallah. Okay, so movement system impairments, that is known as MSI. The discussion on movement system impairments has been ongoing for over 30 years, as discussed by Janda and Sharman. So they say that the importance of the whole kinetic chain and benefits of closed chain exercises is very much equally
Anya,
important. Yeah.
sorry, can you
Sorry.
show the next page where you're reading?
Oh, yes. Sure.
Just
Sure. Yeah. Yeah.
yeah.
Yeah. Sure. Let me just do it for you. Thanks for the reminder. I was just going on with that. Okay. So, yeah, I hope you can see it.
Yes.
Okay. So, can any one of you repeat the sits muscles? We
Yes.
can see we can see from the picture as well, but go
Yeah.
ahead.
So,
Benish, you.
mhm. Supraspinatus, infraspinatus, teres minor, subscapularis.
Thank you so much. So we are not going into the anatomy right now. For origin insertion, hopefully we'll be discussing in upcoming CPDs. So it's just an overview that how the physiotherapists in UK practice in different areas. Yeah. So I wanted people to know that how we can do different techniques to relax and treat the shoulder joint. Okay, so as clinicians, we have moved away from concentrating on an individual joint and instead consider the kinetic chain and how it relates to the whole body. Looking at what MSIs are present throughout the kinetic chain guides our treatment decisions. Incorporating the trunk and lower limb into the patient's exercise program has been shown to be beneficial in restoring movement patterns and seems to be effective in the rehabilitation of problematic shoulders. So we can see from the figure 2 that the flow chart they have just mentioned. So whenever we see a movement fault, it could be due to the joint movement, that it moves too much, either it moves too little, or it has poor timing or control. Do you agree with that?
Yes.
Yeah.
Okay. So, movement in a normal shoulder. The shoulder is the most mobile and inherently unstable joint in the body with muscles that provide the upper limb with a tremendous range of motion. Yeah. So, what are the movements it is capable of? It is capable of adduction, abduction, flexion, extension, internal rotation, external rotation, and 360-degree circumduction in the sagittal plane. The scapula itself can retract, protract, and internally, externally rotate. The other movement it does is about abduction, adduction, and anterior posterior tilt. So the ligaments I'll be discussing, not the attachments again, but just a reminder. You can see from the figure 4, so it is surrounded by 3 types of ligaments: coracoacromial ligament, coracohumeral ligament, and glenohumeral ligament. Yeah. Okay. So now I'll be discussing about dysfunction of local and global muscle spasm. Dysfunction of local and global muscle systems. सारा दिन कह कह के ना मसल स्पैज्म हो रहा है, ट्रिगर पॉइंट है पेशेंट्स को, सिस्टम जो है ना वो स्पैज्म नजर आ रहा है. Okay. So, as previously discussed, the actions of the global and global stability system are adversely affected by pain, and their dysfunction occurs in most shoulder problems. अच्छा, इनके 3 एम्स हैं ताकि पेन फ्री मूवमेंट जो है वो अचीव हो सके. So, what do we have to do basically? By increasing facilitation of the local stability system, increasing tone in the global stabilizers, decreasing tone and lengthening of global movers. Why? Because obviously you need to increase the tone in global stabilizers because they will stabilize the joint. And by decreasing tone and doing lengthening of the global movers, obviously you will be able to strengthen the muscle so that they can provide more movement and increase range of motion around that shoulder joint. Yeah. So they have discussed.
Basically,
Yeah.
simple rule of thumb is like whenever the mechanics is disturbed,
Yeah.
what happens? Some of the muscles get over recruited, some of them go inhibited, some of them are not doing the work in a low tone. So you just have to basically target that. That's the rule of thumb. जो सिस्टम काम नहीं कर रहे उनको अगर आप चलाना शुरू कर दो तो मैकेनिक्स वर्कअप में आ
Better.
जाती है दोबारा. Yeah.
Okay, so there are many ways to achieve this. And Shirley Sherman and Joe Gibson. I think Foster, you follow the techniques of Joe Gibson, yeah? I started that too. Sorry, you
You
can't hear me.
explain it and then I'll just give the demonstration. So you can read it out, explain it, and I'll just give the demonstration.
Okay, done. So they have formulated a series of exercises, and now today we have added those techniques in our CPD module. And ma'am,
Do you know Joe Gibson? Joe Gibson works in here in UK. Joe Gibson is a physiotherapist who works in Queen's Hospital. She's
let's
the one
plan,
who has
meet him.
yeah. I was just looking about her, and I think it's her techniques that she has. She's called the shoulder guru. Yeah,
Him
she
or
works
her?
in
Sorry,
UK.
I don't know about it. She's her. Like, I mean, she's female.
Yeah, Joe Gibson. She's a female.
You
Every
know, I'm
treatment,
discussing about her.
female.
Sorry, guys, I'm discussing about her, but I didn't know male or
You should
female.
know. So Joe Gibson is here in Queen Hospital. It's her course. Yeah, I think she has. I was just reading about her. I wasn't myself familiar. I thought must be some scientist in like 80s or 90s, but no, she's very much alive and she's in UK. She's working.
I think
Yeah.
we should make a plan and let's send her an
Yeah.
email that we want to meet you.
Oh
And
yeah, she's got different videos on YouTube as well. If you type like Joe Gibson courses, you will see. And she explains how the synergy of your muscles is
wow,
disturbed. So all the signs that you are actually reading.
now she will be famous among all of us, inshallah.
Yeah. Anyhow,
Okay,
go
okay.
on.
Yeah. So basically, these exercises aim to restore normal, pain-free shoulder function. Okay, so let me share the next slide with you. Okay, yeah. So now I have this part of the presentation because it shows and discusses the examination part. Yeah. So it says for full examination of the shoulder complex, the patient should always be assessed from all angles. Yeah. It is important to look at scapular movements especially carefully. So what you have to see: alignment, quality of movement, muscle length, strength, and function that should be assessed. Uswa, could you please repeat what I said? Let me just say it again and then you do it, yeah? So, alignment, quality of movement, muscle length, strength, and function.
Yeah. Should I repeat? The alignment, quality of movement, muscle length, muscle strength, muscle function should be assessed whenever we going to examine the patient at the very first time.
Good. Okay. I hope
Yeah.
you guys do it when you assess the patient.
Yeah.
Yeah. Basically, we usually do it by removing the shirt and the patient should be exposed. So we can see the movement of the shoulder, scapular movement, and basically we usually see by the back of the patient. And the patient should be in the standing position, and the therapist should be at the back of the patient and in the standing position, obviously. And sometime patient do it by themselves, or sometime we manually do the shoulder movement.
Perfect. Thanks for adding this. And I think palpation could be added in this, yeah?
Yeah, very important.
Thank you, Usma. Thank you so much.
No
So,
worries.
if any movement is poorly recruited, ask the patient to stand on tiptoes or to bear weight on the opposite foot with a step forward or a step onto a raised surface. Foster, do you mind showing us this position?
Yes,
Yeah,
with pleasure,
uh,
Amna
th-
Jafar.
thank you.
Please don't, please excuse the mess,
No
Janta.
problem. No
I'm going to
problem.
show you the technique. Okay.
So
So
if
when I
Amna
test
can
my
stop
patients, I
sharing,
use,
if Amna can stop sharing the screen so that
Yeah.
we can see Foster in a big camera while performing
Mm-hmm.
exercise. Yeah, that's
बड़े
good.
पैमाने पर,
Yes.
right, guys? So, can you see me full? अब नजर आ रही
Yeah,
है?
yeah,
Yes.
yeah.
So
I
what
can
I'm going to do, so
well.
the technicality of the technique is basically, so you're going to use a TheraBand and it goes around your wrists, okay, and that's the position. So I ask my patient to push it, okay. So when you're doing it, you're engaging your external rotators, which is your posterior cuff muscles. So you're engaging them and you're asking the patient to step forward with the opposite leg. So for example, if my issue is in my left shoulder, I'll be
Mm-hmm.
stepping forward with my opposite leg. So when I'm doing that, so pushing, elevating, and stepping forward in a synergy and then coming back again together. So when I'm doing that, I'm basically engaging the full kinetic chain. So I'm engaging my posterior cuff muscle that's connected, like I discussed last time, latissimus dorsi, and then your glutes. And when you're stepping forward with the opposite leg, so you're basically targeting, you're giving that somatosensory stimulation to the muscles that are inhibited, right? There's another technique that I will add in the end. I wanted to finish with that. That's not mentioned in the article, but yeah,
Okay.
like this. So that's the main principle, and then there are lots of other pictures as well. This is the most commonly used. These are basically called symptom improvement tests. So the minute you do it, you will feel the patient will feel abrupt improvement in symptoms, and they'll be like, okay, this feels a lot better. If I abducted, if I abduct my arm, like if I eliminated without anything, okay, it's painful. But the minute you do the symptom improvement, it's like, yeah, it feels better. So you would
Hmm.
know this is again a confirmatory test that yes, there's movement patterning. This is called patterning, movement abnormal patterning of your muscles. So the patterns develop, like pain behaviors develop. So
Hmm.
as soon as you do the technique, you would know, okay, so that's my diagnosis. Movement patterns are there. I need to connect the patterns, correct the
Mm-hmm.
patterns, and then their symptoms will get better.
Yeah, so
Right.
I think
Continue,
that's
please.
how you're doing the holistic approach and doing that kinetic chain wali thing, yeah?
Yeah.
Yeah.
Okay, so now we'll be discussing. Thank you, Foster. Thank you so much for adding so much knowledge.
No problem.
Okay. Yeah. So the examination, they say that obviously you have to check the posture, external rotators and cuff, forward flexion, serratus anterior, and do the palpation. Yeah. Okay. So with the posture, look for improvement in range of motion when the patient is standing with good thoracic and pelvic alignment. Thoracic mobility is very important due to its effect on the position of the glenohumeral joint. So now we know that why we have to look for the posture. Then external rotators and cuff. Ask the patient to lie with the upper limb over the edge of the bed and their elbow flexed at 90 degrees. I hope all you guys know how to attain this position. In a normal shoulder, it should be possible to achieve this external rotation for the forearm. However, if this is limited or painful, place a pad under the humeral head to correct the excessive anterior glide and see if range of motion improves. So I'll be telling you guys about this position. While I'll be discussing about the exercises, yeah, so I'll show you the picture. Okay, with forward flexion, if the patient finds this painful, applying resistance to the back of their hand through their range of forward flexion facilitates the recruitment of posterior cuff muscles, which may be inhibited due to pain. So yeah, this is important. Foster, would you be able to add something in it, or shall I go
This is
forward
the
like?
same technique I just did, forward flexion,
Okay.
where we
Hmm.
gave resistance on the outside of the hand. So you can do it manually, or you can use a TheraBand on the
Okay.
outside of the hand, like
That,
the wrist is like
that's why
pushing
I
out
asked you
like that.
to add in, because by this the people who are going through our CPD, they'll be more uh, keen to know about I think pictures or videos, but Foster has
Yeah,
just shared that movements. Yeah.
yeah.
Asking the patient to step forward on the opposite foot can also help, as it increases sensory motor stimulation through engaging the kinetic chain, which increases posterior cuff facilitation. Same as
Facilitation.
what Foster has just showed us 2 minutes ago. Yeah.
Yeah.
Okay. So serratus anterior. This is very important for stability as it connects the scapula, thorax, and should always be tested in a patient with scapular dyskinesia. This can be done by asking the patient to lift their arm upwards against resistance when lying in supine. So I'll be discussing this in the other, you know, while I'll be discussing about the exercises. Yeah, just wait for 2-3 minutes. They can also lean against a wall or on all four and try to maintain scapular position of the weight bearing arm. जैसे हम वो नहीं करते हैं कॉर्नर वॉल स्ट्रेचेस करते हैं, उसमें हमारे पेक्स भी ऑब्वियसली एक्टिवेट होते हैं. So same goes for serratus anterior as well. Here we are looking for the ability to maintain scapular position. Obviously your scapula is stabilized when you're doing you are attaining the position that is corner wall stretches or simple wall stretches.
Yeah.
Any improvement in movement when the kinetic chain is stimulated indicates the need for core and shoulder stability exercises. Yeah. Okay, now I'm coming towards palpation. Always look for relative tightness in interior structures. The posterior capsule, pectoral muscles, upper trapezius, latissimus dorsi, long head of biceps, anterior deltoid, teres major and minor. Yeah. So palpation हमने इन सब muscles की करनी है, not चीजें. Sorry, I'm a physio.
Palpation is very important in
Yeah.
any kind of diagnosis. Palpation is one of the most important part of assessment, because then it gives you a clear idea if a person is tender on a certain place, that you would know that that's the origin of their symptoms.
Yeah.
However, if patient has pain in the knee, but they're saying that I've got pain in my ankle, so sometimes I palpate their ankle and their ankle is not painful. It's not the so I would know that it's a referred pain from the knee, because the ankle itself is not tender. Then it's not
Mm-hmm.
the primary source of symptoms. So I had a patient once who came with an ankle Achilles pain, and I was like, I palpated her Achilles, but her Achilles was not tender at all. So when I went on palpating on the upper side of the leg, her knee was very tender. and her quads, the strength was only 3 out of 5. So I
Right.
knew that because of the weakness of the quads, the Achilles are having to overwork. So that
Yeah.
was the main reason. So Achilles, your calves compensate for your quads weakness. So the moment I'd given her strengthening of her quads, her symptoms improved. Her ankle pain was gone. So sometimes the area the area of
Mm.
main origin of symptoms is different. So palpation gives you a good idea
Yes,
Mm.
that where is the, if it's a referred pain or if it's the source of the symptoms.
yes. And I want to add one more thing.
Yeah,
Um,
sure.
because muscles can give you a rapid pain pattern as well as
Yeah.
Foster showed us. So if we just look on the rapid pain pattern of the rotator cuff muscles, sometimes people with the rotator cuff injuries, they can more complain about the elbow pain or just the forearm pain and the wrist pains, but nothing is actually wrong in that area. But still you have to keep focusing on the main primary area, that yes, this patient has originally did something wrong with the shoulder, but now he thinks that shoulder is the pain too, but he is more complaining for some other structures. So again the formula is same. You have to look again on the main parent area which is giving the rapid pains. So yeah, palpation is very very important.
Yeah, that's why it's, and that's why it's really important to see the joint above and below
And below.
the main area. Right,
Okay.
go on, continue, please, guys.
Thank you, thank you, thank you. Okay, so treatment plan. Activate muscle activity in inhibited posterior cuff and serratus anterior. Increase posterior glide and inferior glide of humeral head. Restore normal scapular function and position. Improve posture and thoracic mobility. Restore stability to shoulder complex and kinetic chain. Strengthen any weak or sport specific muscles once the shoulder has been stabilized. So you have to go step by step. Now I'll be discussing about the exercises. So I'm going to share the screen and then you'll be able to understand what we have discussed before. Okay. Yeah. So with exercise 1, it says Sahman external rotation with roll under anterior humeral head to activate post shoulder complex at low level. So obviously we have to start with low intensity exercises, yeah. And as we discussed before, you can see from this picture how to stabilize the shoulder joint, and then you can guide your patient to do the exercise. So exercise 2, this is the wall press for serratus anterior activation in low level. Okay. Then exercise 3, I hope you guys can see, and with these exercises, you will be able to understand what this article wants to teach us. Yeah. So exercise 3 shows shoulder stability. 1, serratus sustained contraction level. So basically, uh, like exercise 1, 2, 3, and going forwards, these are low level exercises, and then after 10, 11, 12, they'll show you high level intensity exercises. Yeah. Okay, so exercise 4, posterior shoulder activation, Joe Gibson level 1. So this is the same exercise Foster Joseph has explained. Exercise 5, Sarman quad start and end positions. So see, we are discussing shoulder joint, but with these exercises, you can see that whole kinetic chain has been involved. Yeah, whole body is doing some work to activate and inhibit different muscles. Exercise 6, Sahman Y to activate serratus through range, because we want to increase the range of motion for different muscles that are surrounded in the chest area, in the shoulder joint, and the back. Stretch 1. Pillow for posterior capsule to allow humeral head posterior glide. So you can see how you can mobilize the shoulder joint because you want
I'm
to.
trying to envision. I'm trying to envision this, like how this movement will help. Can anyone just? I'm a bit confused in this stretch one,
I
like
think
how
because
it will
you're doing
allow
posterior glide.
posterior glide.
Yeah, because you're giving a shoulder posterior glide. So I think with posterior glide, internal rotation increase hoti hai. Sorry if I'm not
No,
messing up
with
around
posterior.
with the movement.
So with posterior
No,
glide,
this is externally rotating. She is improving the external rotation because she is resisting the external rotation, not
yes,
I
like
think with the posterior glide, forward
yeah,
flexion would improve because it's concave convex now. So the movement of your bone will be opposite to the glide of your joint.
yes.
If it's going
I think
posteriorly,
people
then
can also comment while looking after this PPT.
yeah. Can
They can
someone help
comment.
us? Just give us
Yeah,
comment
please.
on
So
this
Please
one.
comment. I hope we have our seniors so they can just
Kenny
guide
wants
us.
to say something.
yeah, I just want to add,
Yeah.
your shoulder is
Can't hear you. You are mute, Binish. You are mute.
Finish.
Oh, sorry. Okay. I was just I just want to add one thing. Your shoulder is always working on convex concave rule, which means to
Yeah.
improve your range. To improve your flexion, you have to give posterior glide. So
Posterior
this,
Yeah.
glide. Yeah.
so but in this picture, Uswa is right. But that patient is already in external rotation, and she is adding just a stretch. So I was even assuming the same thing, that how this stretch will be, going to help. So it's more like external rotation stretch,
Hmm.
and it's a
Don't
posterior
you think it's
glide
more
as well.
internal rotation?
Sorry.
Don't you think, if you see the picture, don't you think that the woman is given more internal rotation because her arm is down instead of
इसलिए
backward?
मैंने
Can
पहले
you
भी यही कहा कि
can you
internal.
show can you show the picture? I think
Yeah,
it's more
sure.
internal rotation
she's
rather than
applying
external
force
rotation.
as well against the movement from other hand, which I am going to perceive.
I don't know if it's against the movement or if it's a stretch, if it's just giving the end range stretch on that.
Because she is placing the other
मैं
hand on the
बताऊंगी,
wrist.
मुझे जो
Can
लग रहा
you
है ना
zoom? Can
She's
you
she's
zoom
placing
that?
the other hand on the wrist like this movement. She's trying to move this movement like isometric movements. This is
What does what
no
does it say?
no length,
Pillow
no
stretch.
function, but still this is isometric movement, I guess.
Pillow stretch for
नहीं तो फिर
posterior
posterior
capsule.
glide कैसे आएगा humeral head को?
Dear, for Uswa
You
is
can
very
also
right.
feel yourself. See, I'm feeling myself. My shoulder posterior glide is happening. Like if I feel myself, like if I resist my external rotation, I feel myself in the shoulder that there is some movement, there is some opening at the posterior side. So if someone lay down, then it would be more obvious.
You are very right, Uswa. Considering still again the Kelton-Born convex concave rule, if you see with external rotation how your humerus head is moving, this is again the same glide. So it's more like a posterior glide on your capsule, while patient is stretching external rotation.
Yeah. No. I think it's the internal rotation. So if you envision it, right, when you do internal rotation, so it's going backward, it's going posteriorly. Can you
Yeah.
envision it? So let me
Okay,
show
so
you.
I think we'll
So
be.
let me show you. Let me show you. So that's your joint, that's your accessory, right? And that's your bone, right? So when you're doing the internal rotation, the joint is going posterior. So the joint is going back. However, when you're doing the external rotation, the joint is coming forward.
Yeah, this is
You know what
obvious.
I mean?
Yes.
So
Yeah.
when you're doing the internal, the joint is moving back.
Hmm.
So it's a posterior glide for your joint, but your arm, so the bone movement will be opposite to your accessory movement of your joint. So that's just envision it.
I was.
Does it
I
make
was.
sense now? So I think it's more internal rotation
Hmm.
stretch. So now I can feel my joint is going. It's likewise. It's likewise when you move your arm up, the glide is
Hmm.
inferior. You know, when we give mobilization with movement glide,
Yeah.
patient moves their arm up and we give the
Hmm.
inferior glide. So when the glide is inferior, the bone is going up. So it's always the
Hmm.
opposite. So if your arm is going forward, then your joint is going backwards.
Ah,
Hmm.
yes, you are right.
Yes.
Does it
So
make sense?
मेरा तुक्का जो है वो सही लगा शुरू में internal rotation.
तो कनकेव कन्वेक्स यही रूल है ना. कनकेव
हाँ.
कन्वेक्स क्या है कि मतलब जब आपका
ऐसे फील हुआ था कि
because the ball is convex. When convex is moving on concave, it's the opposite. However, if concave is moving, then concave and वो glide और bony movement same जैसे आपका knee होता है.
Agree.
Knee के interior glide है तो movement भी interior ही है.
100.
Like extension of the knee में glide भी interior आती है और flexion of the knee में glide भी posterior आती है.
Sorry,
Yeah.
guys, I have to interrupt you because the meeting will be over in 3
Sorry
minutes.
guys, yeah, continue.
Yeah,
Yeah,
no
continue.
problem. So with exercise 7, ball roll out for shoulder stability. This is a good exercise. Posterior shoulder activation, Joe Gibson level 2. Now we are going towards high resistance activity exercises. Exercise 9, bird dog for stability and strength. Arm lift.
I think that was the test for serratus anterior as well. वो जो serratus
Yeah.
anterior का test है ना कि all fours पे जाके you have to check the scapular rhythm. I think जो test है ना वो ही बाद में treatment भी है.
Treatment.
Like the test of symptom improvement, they are the treatment exercise.
Yeah. Then exercise 10, shoulder stability on the ball, that is harder, elbow support and leg lift. Exercise 11, Superman on the ball when stable, lift arm first and then leg. Exercise 12, posterior shoulder activation and strength, Joe Gibson level 3. Exercise 13, lower trapezius activation and strengthening.
I can do it
Exercise-
as well. I've got the ball.
Yeah.
Yeah, go on. Sorry, I'm just trying to like
No problem, no
do
problem.
it.
Exercise
Yeah, go
14.
on.
Shallow dive on ball with TheraBand for stability and strength.
You see, it's
Stretch
like that.
Or stretch to release pecs and anterior tight structures. So
Superman,
that
guys.
was all.
You cannot raise your legs.
Yes, because I'm fat.
No, you are healthy. You are not fat.
Okay, so we
I
are
I
done.
can't understand if I am on the ball or if ball is on the ball.
But
Okay, guys, I want to add one point.
Yes.
I have been searching out that the shoulder pathology is more in the man as compared to woman, because the man do this mostly sports work, because the country in which we are living, there is very less because there is no gender differences. So everyone is equal. So according to the things I have been searching out, they say that because of the estrogen level is very much in the woman till a specific stage of life, so that's why it caused less pathology to the woman. And man has more pathology because of the musculature. They have the big musculature and the bone
But this
alignment.
is women
So-
are prevalent to have these shoulder instability problems.
Yeah.
Sorry?
No, the one that you are discussing, it's general, all over shoulder, like all over, like because frozen shoulder is more common in women.
Yeah.
Okay, it's talking about general overall shoulder, like overall shoulder pathologies are more common in women. To be honest, most of the diseases are anyway more common in women. और कोई भी disease उठा के देख लो, women are more affected. But still, for some reason, we have more population of women. Men फिर भी जल्दी मरते हैं. Although how much issues we have, like women को कितनी मुसीबतें आती हैं. But men are the one who always die first.
But still,
rotator cuff,
women are very
you might be
strong
right.
considering the deliveries and things like that. Women are very
They
strong.
are, yeah. Like I mean, the universe पूरी तरह से फेंकती है. बीमारियां भी हर चीज फेंकती है औरतों पे. But we are survivors.
And
We
most
survive.
of that stress, women faces a lot of stress.
अच्छा guys, I want to add one more thing before this meeting stops. हम discuss कर रहे थे about symptom improvement. So I want to add, I think मैंने comment भी किया था ये कैंडी के उस पे Facebook post पे. There is another very nice symptom improvement. You can use this, right? If this one doesn't work, if the rest of doesn't work, use a tennis ball. Use a tennis ball and ask them to squeeze meanwhile they elevate their
Yeah.
arm.
That
And you will
would
see
be
an amazing symptom improvement with this one. If that doesn't work, pincer grip. Ask them to do a pincer grip. Squeeze pincer grip and do. This kinetic chain also takes overload because you engage your bicep and tricep. They are also global mobilizers. So this engages your bicep and triceps. So this is a really good symptom improvement test as well. I use it when other symptom improvement doesn't work. जब ये वाला वो सारे काम नहीं करते, I just ask them to squeeze a ball. They're like, wow, it feels magic.
Exactly.
yes,
And
this is the
sometimes
exercise
just
for you.
because of the pain, people are really having high irritability, and just try to distract them by adding some different means, as Foster explained.
Yeah,
So this is quite a good idea.
you will see. Try this with your rotator cuff patient. You'll see the difference. They'll be like, oh my god,
But
totally.
it was really a wonderful CPD. Thank you, Amna.
Well
And
done, Alma. Well
every
done.
time,
A
and to
huge
be
round of
very
applause
honest,
for you.
yeah, and we learn from each other every day, and we believe that those who are watching us, and they can even, send us some requests that what further we should explain, or on what topic.
Yeah.
Yes, suggestions.
Um,
Yeah, we need some suggestions, guys. If you are
yeah,
struggling with any kind of
I'm receiving some comments on Achilles tendinopathy, which is quite common as well. So people
yes,
want to
we will be
have
discussing
assessment of
about it.
that and the rehabilitation. So yeah, that's
Yeah.
a good idea. People can continue asking us, and then we will try our best.
Yes, we will. We want. We decided to do it region wise, like do the shoulder things first. But it's not hard and fast. We can do anything. जिसको जो भी उसको feasible लगता है, you can pitch in. After all, knowledge is knowledge anyway. अब
Yes.
shoulder में तो इस तरह फिर हजार बीमारियां हैं. We can't like discuss everything. So
Hopefully,
just
we
discuss.
are helping ourselves and others as
Yeah.
well.